Hello and welcome to the PrecisCa Multidisciplinary Genitourinary Tumor Panel. My name is Jason Abel. I'm a urologic oncologist at the University of Wisconsin. To begin, we'll just go around the panel, introduce yourself and your expertise. Dr. Melnick.
My name is Vincent Melnick from Washington University in St. Louis, and I'm an abdominal radiologist.
Hi, my name is Matt Reddick. I'm a medical oncologist specializing in genitourinary malignancies.
I'm Larry Keston, a radiation oncologist in the Detroit, Michigan area. I'm the medical director of the Michigan region for MHP Radiation Oncology Institute and Genesis Care.
Yes, I'm Ethar Derwish. I'm a urologic oncologist at the University of California, San Diego.
This patient was initially diagnosed with invasive urothelial cancer and completed chemotherapy, radiation, and TURBT. The patient was then represented 6 months later with local recurrence and a biopsy proven vertebral metastasis at L4. So what are the recommendations for next steps in treatment? So the patient presented initially to the emergency room, had urinary hesitancy, scant hematuria, and some abdominal discomfort. He was ECOG performance status 0 at the initial diagnosis. Past medical history, the patient did not have anything significant. He was a former smoker, 80 pack years, quit in 2010, drinks socially, no drug use. The patient is a retired construction worker and lives with his wife. His father did have pancreatic cancer and his mother had gastric cancer. From his oncologic history, begins in July 2019, had a CT of the abdomen and pelvis, showed some bladder wall thickening and bilateral renal cysts, had cystoscopy, multiple papillary tumors were identified, positive for invasive high-grade urothelial cancer on cytology. In December 2019, the patient underwent a transurethral resection of bladder tumor, which showed invasive high-grade urothelial cancer. It was PD-L1 negative. CT chest showed no evidence of metastasis. CT abdomen renal protocol shows only bilateral renal cysts and a questionable L4 lesion. So Dr. Derwish, what do you discuss when you counsel patients who present with non-metastatic muscle-invasive bladder cancer who are considering the options between radical cystectomy or a trimodal therapy approach with radiation chemotherapy and TURBT? And also, could you discuss how you counsel patients regarding neoadjuvant chemotherapy?
Those are very, very key questions that should be a part of every complete discussion in a patient who presents with muscle-invasive disease or even local regional disease with with oligometastatic disease. Certainly in a patient, if we're going to be discussing a multimodality approach, whether it's radiation therapy and chemoradiation versus radical cystectomy, I think that the emerging data that should be discussed is that that chemoradiation is a valid alternative to surgery for patients who do not want to accept the morbidity of extraoperative surgery. I do think that there is a proportion of patients that may still fail and may then require more complex or high-risk salvage therapies in this type of situation, and that discussion should be engaged in with the patient, as well as the discussion for morbidity that may be associated with a bladder sparing approach, especially with respect to local abdominal and pelvic symptoms. In terms of the discussion for patients with respect to neoadjuvant therapy prior to cystectomy, the discussion should focus on data clinical trial data that shows that patients who have muscle-invasive disease and who undergo neoadjuvant systemic therapy tend to have improved outcomes, and that overall getting a systemic therapy prior to surgery can improve outcomes from a variety of different standpoints and is often better tolerated than patients who may be trying to get or who may want to think about systemic therapy after primary surgical therapy. So for a patient who can potentially tolerate it, it is something that I would recommend in patients who are candidates for radical cystectomy.
Great. Dr. Rettig, in a patient treated with a neoadjuvant approach for chemotherapy, how do you assess treatment response?
So that's tricky. The patient really doesn't have metastatic disease, and so there's not a clear measurable lesion. Typically, what I do is complete the neoadjuvant cisplatin-based chemotherapy and get a restaging set of scans prior to the surgery, the cystectomy, the removal of the bladder, just to make sure that the patient hasn't had any obvious disease progression, either locally or with the onset of metastatic disease, which would be uncommon but possible. So that's typically how I approach it. I usually wait about 3-4 weeks after the last cycle of chemotherapy has been completed and get the restaging scans before I tell the patient he's clear to move forward. He or she is clear to move forward with the surgical resection.
Great. And Dr. Rettig, are there any benefits in the neoadjuvant setting for gemcitabine cisplatin versus a regimen like MVAC for bladder cancer?
Yeah, that's a great question, Dr. Abel. The clinical trials that were conducted, the phase 3 studies that showed a survival or disease-free survival advantage to neoadjuvant chemotherapy, meaning chemotherapy before the surgery, did utilize a regimen, a 4-drug chemotherapy regimen called MVAC, MVAC, with each letter associated with a different chemo drug. Technically, the regimen of 2 drugs, gemcitabine and cisplatin, has not been tested in the neoadjuvant setting in a randomized controlled trial, but there has been a comparison of MVAC to the 4-drug regimen to the 2-drug regimen in the metastatic setting. And in that context, the 2-drug regimen, the gemcitabine and cisplatin, or GC, provides very similar control of the disease, but much less toxicity. So in general, in medical oncology, we translate those findings in the metastatic setting to the neoadjuvant setting. And we rarely use the 4-drug regimen MVAC, which is a lot harder to take.
So we can see in February 2020, gemcitabine and cisplatin was instituted. The patient had a biopsy of the L4 vertebrae, which did not show any evidence of malignancy, and the patient completed cycle 4 of gemcitabine and cisplatin in May 2020. He underwent a repeat TURBT, which showed residual non-invasive disease without lymphovascular invasion, and the patient declined invasive procedures, specifically cystectomy. So in September 2020, the patient was treated with definitive bladder intensity modulated radiation therapy with 55 gray in 20 fractions. Dr. Keston, could you describe this approach for definitive radiation for bladder cancer?
Certainly. I agree with Dr. Derwish's and Dr. Rettig's comments earlier, and one option is certainly to proceed with chemotherapy followed by radical cystectomy in this situation, and another option is to try to perform a bladder preservation approach. Typically, if we perform a bladder preservation approach, one can begin with concurrent chemotherapy and radiation treatment simultaneously. In this particular scenario, we would have the opportunity to add radiation treatment at this point, which looks like it happened in September of 2020. Even after some initial chemotherapy, as occurred in this particular patient, we would still typically give concurrent chemotherapy with the radiation treatment at the same time. That's the preferred method. And then there are a few different approaches in terms of radiation treatment. In all settings, as I discussed earlier, the bladder will be treated throughout the entire radiation treatment course. Sometimes the lymph nodes are treated electively. I personally typically treat the lymph nodes electively, especially the lower pelvic lymph nodes. And then give a higher dose to the bladder, or in some settings, even a partial bladder boost if the tumor within the bladder can be easily identified. There are, again, several different radiation therapy regimens. The most common in the United States is typically a regimen where we give 1.8 to 2 gray per day, which is called standard fractionation. And that regimen would typically lead to at least 36 to 38, 39 total treatments, total dose in the range of 64.8 to 68, maybe even 70 gray. An alternative and appropriate regimen is to use 55 gray in 20 fractions, which was chosen for this particular patient. Obviously, it's a 4-week treatment course, so maybe more logistically feasible for this patient. And it is, a well-established, appropriate regimen. I typically choose the more standard approach, as I think that has a little less long-term toxicity and probably is a little easier to give concurrent chemotherapy with that regimen.
Great. So we can see the patient presented back to the emergency room in a few months later and had some progression with bilateral hydronephrosis on a CT scan and bladder wall thickening, and had bilateral percutaneous nephrostomy tubes placed with resolution of the acute kidney injury. The patient then underwent a repeat TURBT, which showed recurrent invasive urothelial carcinoma without muscularis propria identified on the specimen. So the patient underwent a restaging PET CT in March 2021, which shows heterogeneous FDG uptake throughout the thickened bladder wall, hypermetabolic L4 lytic lesion, and pelvic lymphadenopathy. The patient was admitted for back pain and underwent an MR of the lumbar spine. Dr. Melnick, could you comment on the imaging we have here?
Yes, thank you, Dr. Abel. This is a fat-saturated post-contrast T1 weighted image that's a sagittal image through the lumbar spine. I mentioned that it's fat-saturated because the normal adult bone marrow should look relatively dark on this sequence. Most adult bone marrow is comprised of fat, and corresponding to the findings you described is increased enhancement within the L4 vertebra there. That certainly looks suspicious for a marrow replacing lesion and a metastasis. Interestingly, the patient had a previous biopsy, presumably of this location, that was negative. The data of the increased uptake on the PET CT is useful, but it may be appropriate to get perhaps a bone scan to make sure there aren't other sites of disease. If it would alter the patient's treatment, you certainly could attempt a repeat biopsy of this level. Probably also notable for the patient's care is the lesion doesn't appear to be extending through the posterior cortex of the vertebra into the spinal canal. But findings concerning for metastasis all in all.
So you can see that the patient did get a repeat bone biopsy, which again shows PD-L1 negative, high-grade metastatic urothelial cancer. The patient's performance status is now worse, ECOG performance status 3, lower extremity edema, back pain, penile and scrotal edema. Dr. Keston, is there a role for palliative bone radiation in a patient like this with bone pain?
Certainly. If a patient has a bone pain in this scenario, or a nerve impingement of some sort, it would be very reasonable to add palliative radiation treatment. Potentially in this particular situation, if this is after complete staging, if it's a solitary site of metastatic disease, then one may consider even a more aggressive radiation treatment approach, especially maybe if we were able to give some initial systemic therapy and demonstrate some stability. But a palliative treatment course here would be reasonable. It would typically consist of treatment over a period of about 1 to 2 weeks.
And so, Dr. Reddick, what systemic therapies do you discuss with the patient now that they appear to be progressing and have a poor performance status?
Yeah, so I think the patient's poor performance status makes further systemic treatment a little bit more challenging. With that said, there are therapies that can be used. So typically the second line treatment after chemotherapy, especially when the duration of remission is just a matter of months, would not be to repeat chemotherapy, but to go to an immunotherapy, a checkpoint inhibitor, such as pembrolizumab, which has, I think, the most robust evidence for efficacy in this particular setting. I would consider doing it in a patient with an ECOG 3. In general, patients tolerate immunotherapy quite well, and I would probably give it a try with the careful monitoring of the patient, and if there was any signs of early and meaningful toxicity, I would abandon therapy. At the same time, I would take the tumor tissue, whether it's the tissue from the primary tumor or the metastatic lesion at L4, and send it for genetic sequencing, somatic sequencing, next generation sequencing, to determine if the patient has an actionable mutation. Given that there are some oral agents that can be used and reasonably tolerated, but even for patients with an ECOG performance status of 3, indicating a decline in their functional status. So I think it's a difficult question. It requires a lot of discussion with the patient and coming up with what we call a shared decision about the next steps. Some patients may not want anything else, and some patients may want to continue to take an aggressive course, and either approach is very reasonable, and I would try to accommodate the patient's wishes and inform them of the potential benefits and, of course, the potential toxicities or downsides of any other therapy.
So in a patient with metastatic bladder cancer who's progressed after the initial treatment with gemcitabine and cisplatin, as well as definitive radiation, the multidisciplinary panel today discussed the next steps to consider would be palliative spine radiation for the symptomatic lesion, immune checkpoint therapy with pembrolizumab, next generation sequencing on the tumor tissue to evaluate for any actionable mutations or alternative therapies.